Well, good afternoon. It's been a long session, I know. We've had many exciting presentations. This afternoon, with your permission, again, I am double vaccinated, so a bit of a distance if you guys are okay. I'll just take my mask out for a bit. So I wanted to welcome you to this session. The challenge of doing this session is that it's a wide topic. I think the last 2 days we've been talking about how to actually take the hospital out of its environment. Now there are many aspects to how we can do that. The session today essentially is to look at how we can do some practical things, either in terms of research, either in terms of actual experience of how to take the hospital out of its boundary. So today we have 6 presentations, and there'll be a variety of presentations essentially, looking at practical experiences, how this was done. Now, my own background is I'm a CEO. I've been running hospital systems globally. I used to run hospitals for Johns Hopkins, Aga Khan University. So my background is all in delivery of care. So I'm very excited to be here, part of this group, to talk about some practical experiences of moving the hospital out of the environment of the walls we have. So with that, I'm not going to spend too much time on the background of each of the presenters. I'll just present who they are. I'll give them a bit of opportunity to talk a bit about their institution. And then the dialogue is really going to be one of actually them giving their experience of projects they've done. Now, by the way, you're very welcome to use the app to ask your questions. We will have some time at the end, about 25 minutes, to go through some Q&A. So with that in mind, again, please look at your app, send the questions over. And without much more ado, I'm just going to quickly introduce our first speaker, and then get into the topic, and maybe you can introduce the topic as well. So the first speaker is Dr. David Nicholas, and he's the medical coordinator at the Hospital Clinic de Barcelona. So over to you, David.
Thank you.
Did you want to present from here?
Yeah.
Yeah, and you can use the mic here, by the way.
Okay, thank you very much. We're created, or our unit was born in 1986, and nowadays we cover a population of 600,000 people here in the left area of Barcelona, so we are kind of playing home right now. For this, we have 60 virtual beds. That means that we can have 60 patients admitted with us at the same time. And to do this, we have this wonderful staff composed by 18 nurses, 2 advanced practice nurses, 5 physicians, and 2 administrative staff. In a regular year, we can have 1,100, 1,200 patients admitted with us, but in 2020, we experienced an increase in patients. We doubled the number of patients we attended at home or out of the hospital context. We had our usual 1,000 non-COVID patients, but we also increased 1,100 COVID-19 patients. To cope with this, we deployed 3 different strategies with 3 different alternatives to conventional hospitalization that I will go in more detail now. First of all, we adapted our usual hospital-at-home work to treat COVID-19 patients at their homes, and we are still doing. We adapted a hotel, we medicalized a hotel for treating COVID-19 patients that otherwise would be admitted to the hospital. And also we created a virtual hospital for infected healthcare workers. First of all, the hospital at home, well, we for a few months, we fully dedicated to COVID-19, and now we are, from the last year, more or less, we've been combining COVID and non-COVID activity at home. The admission criteria for COVID-19 patients, briefly, would be a requirement of oxygen under 3 liters per minute, because this is the maximum flow that we can provide at home, a respiratory rate under 26 respirations per minute, and to present a bilateral pneumonia in those patients without risk factors for a severe COVID-19, such as elderly or immunosuppressed patient, or a unilateral pneumonia in patients with those risk factors. Our intervention was the usual hospital-at-home intervention, daily in-person nurse and physician assessment, the usual test, AKG, blood test, ultrasound. And for treatments, we provided oxygen, nebulized treatment, and those specific treatments for COVID-19 that were available at each time in the hospital: corticoids, hyperimmune plasma, remdesivir, tocilizumab. We also created an emergent transfer circuit for those patients requiring an escalation of care and transfer back to hospital to be transferred directly to a hospital ward or to the ICU. And since March to last month, we admitted 309 patients at their home. Nearly 1/3 of the patients came directly from the emergency room, and the rest came from hospital wards. The mean age of our patients was 56 years old. 71% of them required oxygen supplementation at their homes, and nearly 80% received any specific treatment for COVID-19. Regarding the outcomes, 95% of the patients were discharged from home directly, and only a 4.6 required readmission back to hospital. From them, 5 went to the ICU, and finally, 2 of them died. Our second strategy coping with COVID-19 and preventing overwhelming of hospital clinic was to adapt a medical hotel that you may have seen outside there in Plaza España. That is the Hotel Plaza. It's a 4-star hotel with 500 beds. We deployed there a team of medical staff, nurses, technicians, administrative, security staff, and also some medical equipment. You can see there a point of care, there was an X-ray machine, there was a pharmacy. We also made some adaptations to the rooms. We provide oxygen flow to 2 of the floors of the hotel with a 5,000-liter tank of oxygen there in the street. And also we installed some video surveillance in some rooms for those patients more critical. Between March and May, the 2 months that the hotel was open, we admitted there 516 patients. That represented 20% of the total of patients admitted in hospital clinic in the same period, patients that otherwise would be admitted in the hospital clinic. 60% of them were patients coming from hospital wards, and 40% were coming directly from the emergency room. The average stay was 9 days. 5% of the patients required transfer back to hospital due to clinical worsening, and the rest, 488 patients, were finally discharged from the health hotel directly to their homes. Lastly, the third strategy that we put in place was a virtual hospital for infected healthcare workers. You probably recall the drama of colleagues being infected. Our hospital decided to perform weekly screening for COVID in all first-line healthcare workers. And when they tested positive, they were given the sick leave and were admitted directly to our hospital at home unit. We admitted them in the electronic record system, and we classified our colleagues into asymptomatic, that only required virtual assessment by phone or video call each 24 to 48 hours, and those symptomatics that were given a self-monitoring kit, very simple, for measuring blood pressure, measuring oxygen saturation, and were called or video called daily. When we found any alarm sign, they were transferred or assessed at home if they lived in our catchment area, or transferred to a dedicated clinic for their assessment, x-rays, or treatments. This was working for 5 to 6 months. In that time, 610 workers became infected with COVID-19. The mean length of stay with us was 15 days, and luckily, only 6 colleagues required hospital admission. And from these 6 patients were finally discharged without more problems to their homes. Only 3% of the workers required further assessment at the hospital for test or any other visit. So, and with this I will finish my presentation. Alternatives to conventional hospitalization, such as hospital at home units, are key to avoid systems collapse more than ever in these pandemic times. Our units have the experience in treating high complexity patients in the out-hospital setting, and we are very resilient, very flexible, very easy scalable units. With an optimal selection of the patients, and this is crucial, this is vital for it to work, alternatives to conventional hospitalization are safe and efficient. And lastly, to finish, the Hospital Without Walls model offers a patient-centered medicine, empowering patient and family. this is another picture of the team. It's more casual. I like it more. And thank you very much. And I'm ready for questions or content.
Thank you, David. Yeah, we'll actually have a lot of opportunity for questions and answers at the end. I think one thing, David, when we come to the end, when we have Q&A, this is after the question that's going to come up. Think about it. We'll get to it. How much of this is a process that now becomes part of the normal process? This was a one-time event. Can this become a regular process? So we'll come back to that. So, we'll now get to Ghislaine Promenet, who is the Deputy CEO at Fondation Santa Service in France. Please.
Thank you. Thank you for attending this presentation, which aims to show you an innovative response through hospital at home, so quite similar actually, to overwhelmed hospital by avoiding hospitalization of acute patients who are in the early phase of COVID. So that's the most risky phase of COVID and who require oxygen therapy. Oh, it's missing a slide. So it was a partnership between one hospital, one major hospital, which is Argenteuil Hospital, which is in the Paris region, and it's emergency department, which is almost 100,000 visits per year, and our HAH, which is a larger hospital at home in France and certainly in Europe. Just last year, we treated 16,000 patients, and we have, on average, more than 1,800 patients a day. And we can treat chemotherapy, palliative care, wound healings, but also rehabilitation, but also monitoring of high-risk pregnancies. And so from November, that is to say, from November 2020, that is to say, in the second wave of COVID in France, the Argenteuil Hospital, which launched the project, came to us, and because the hospital wanted to. I'm sorry, that's not the presentation I gave yesterday. It's an old one. The Argenteuil Hospital came to us and asked us to take in charge those patients straightly from the emergency department. And at that time in France, there was a debate in the medical community whether one can or not take in charge at home patients, COVID patients with oxygen therapy. And the Haute Autorité de Santé, which is a national health authority with scientific societies, provided in November the 9th what they call quick answers to give the conditions, the criteria to treat at home COVID patients with oxygen therapy. Then the journey of the patient, the decision is made by the emergency physician based on the criteria of the quick answer. As you can see it, there were environmental criteria and clinical criteria quite close to those presented before. And the admission can be made every day of the week. That is to say, in a usual hospital at home in France, there is an assessment of the patient by our nurse at the hospital. But in this case, the patient was discharged from the emergency department, and sometimes we haven't time to assess it in the hospital, so we had to do it based on the criteria at home. Then, after going home, the patient was daily monitored, as it was presented before, by our nurses, and there was a daily reporting to the emergency department through the regional information system, which is called Terri Santé, but anyway, and through face-to-face meeting between our coordination nurse and the head of the emergency department. So for what results, what outcomes? So as you can see, we have been treated more than about 500 patients, and we went up to 117 patients a day at the peak of the third wave. That is to say, as many beds freed for the hospital. We had 35 patients who were readmitted to hospitals. That's quite the same average with the former presentation, and we had no death at home, hopefully. And the average length of stay was almost 19 days. So what was the pros of the journey? We reached the objectives of the hospital. That is to say, we managed to free up beds for the real patients in need. We managed to not overcrowd the emergency department. We managed also to have a low rehospitalization rate. And we had also a rather good patient satisfaction because patients could be at home, surrounded by their caregivers or family, and in a more safer environment. And for the foundation, that was also a good point because it contributes to an active and frontline management of the crisis for us. And last but not least, it enhanced our relations with one of our major partner between hospital and our hospital at home. I can mention, with pros, there are always cons. I can mention one or two areas of improvement. First of all, there was no inclusion of the GPs on the patient's own GP, and that was a weakness of the past. Second area of improvement, I've told you that we used the information system, the regional information system used by the hospital. And actually, that wasn't our information system. So our nurses were compelled to have a double entry of reporting every year. That was a real difficulty for us. So what takeaway for the future of hospital at home, at least in France? In a usual model in France, the hospital at homes enables to reduce the length of stay in hospitalization. We assess the patient at the hospital in an upstream preparation, and then there is a discharge from the hospital. In this case, we've shown that we could avoid hospitalization through quick admissions through hospital at home. But the question for us now is to know whether we can replicate such a model in a non-crisis context. And we work on it in two directions. The first direction is to work on specific disease or specific treatments. And we work with the hospital on geriatric patients with predefined criteria. And the second direction is, of course, to work on still better cooperation between hospital and hospital at home in every extent. That is to say, between doctors, between nurses, between also our information systems. So I hope that next year we could present you a generalization of care at home for post-emergency patients. Thank you for your attention, and sorry for the presentation, which wasn't a good one.
Well, thank you, Ghislaine. You recovered really well, so thank you. So we have a few minutes. We're ahead of schedule, so I'd like to pose the two questions that are coming up. So the whole question of replicability. You mentioned in your presentation that the whole question of is this going to be replicable after COVID? So I'd like to ask you that question, Ghislaine, and then David as well for you. Is this model replicable? Two key issues that are coming up right now. What's your sense? And you don't have to have all the data, by the way. We're asking you as the group, as the co-CEO, what's your gut feeling on this one?
I think we can replicate this model, but as I said it, we've already experimented post-emergency hospital at home, and it wasn't...
Can we get the mic?
Yes.
Sorry, yeah.
Thank you. So we already made experiments before the COVID crisis, and the experiments were not successes. But as I told you, and I tried to show it, if we work on specific patients, specific treatments with predefined criteria, we can accelerate admissions, and I think we can replicate it, and we work on it currently.
Okay. And David, as you answer that, replicability and acceptance. At the end of the day, is it going to be accepted?
I think that if we take out the hotel part, that was very extraordinary and very bizarre, and I hope we won't do that anytime soon. We didn't do anything that we weren't doing before. It's I told you so sensation. We were doing this before for other kind of patients. We were admitting patients from the emergency room directly. There's no here.
Good. That's
Okay.
better. Yeah, keep it close to your mouth.
Okay. We were already admitting patients directly from the ER. Nearly the half of our patients come directly from the ER. So maybe we have gained some visibility, some credibility with other partners in hospital, and in this way we are now going through two different paths. One is to prevent admissions from the primary care, from the GPs directly, and admit patients at their homes and avoid the ER consultation. And the other one is to shorten the length of stay of surgical patients. This is an opportunity that came from this crisis, and we are exploring it.
Okay, thank you. So with that, we'll go to the third presentation by Merixel Lopez Hernandez, who'll be talking about the final consultation by nurses key to emergency care efficiency of a regional hospital. Now, I think Merixel is going to need some help for translation, so we'll be doing dual translation, yeah? Okay.
Good afternoon. My name is Merixel Lopez. I'm head nurse director in Viladecans Regional Hospital in Barcelona. And she's...
Carmen Quintero. I'm an emergency room physician at the same hospital, and we'd like to give our regards to the organization for allowing us the opportunity to present our hospital's project regarding nursing management in acute emergency care. For the longest time, there has been many conversations concerning our healthcare system where there's an increase in demand of acute and urgent care from an ever-growing population, where technology is in constant state of development and evolution, and where resources are scarce, and we have to cope with the situation. For this reason, we believe that it's necessary to seek out new formulas and solutions in order to help us optimize our resources and to provide a better quality of care. One of these solutions for which we have strongly opted for is the redirection of healthcare provider roles, which is a different way of approaching the increasing demand in acute care in the ER, and that will impact results in healthcare workers. We will focus in the emergency department at our hospital, where we roughly treat in between 140 and 160 cases per day. As we can see, the demand of urgent care at our hospital's ER department is in constant rise, reaching almost 5% more as compared to the previous year. If we divide according to level of triage, we can see that 60% of ER visits are either level 4 or level 5, which are considered less urgent or non-urgent cases according to level of triage and care. This surge of less urgent cases causes an overflow in the ER, which results in delayed medical assistance and longer stays in the emergency room. This all translates into a decline in overall patient satisfaction and as well as the healthcare workers themselves. So, what we can do at our hospital, considering that approximately 60% of patients that are treated in the ER come for health problems, which are classified as less urgent or non-urgent cases, and that there's an excellent doctor-nurse relationship, and that we have a highly skilled nursing staff, we have proposed the possibility of incorporating nursing professionals as the finalists in medical care in the ER. We are are not referring to triage or advanced triage, such as, for example, when a nurse manages pain in a patient or orders a lab test while they wait to be seen by a doctor. This is a different focus. With the incorporation of the GITA program, we are creating a highly skilled nursing consult where the patient will be evaluated, diagnosed, and discharged for less urgent and non-urgent cases by a nurse practitioner. For this reason, we established the following objectives, which was to define a new role in ER nursing by empowering a level of competence in these professionals, a greater patient accessibility to emergency services with the same quality and safety of care, and promoting greater professional nursing development as an advanced nurse practitioner. In all, 39 guidelines were developed in order to treat 57 chief medical complaints. To kickstart the GITA program, we first built an ER doctor-nurse work group in 2019. We carried out an analysis of the most frequent chief complaints of less or non-urgent cases, considered level 4 or level 5, as I previously mentioned, and we determined which were less complex. Emergency care flow was also redefined, integrating the GITA figure into its program. In order to standardize nursing care, practice guidelines were developed. Each guideline defined a reason for consultation according to a main health problem. On the other hand, considering that we were creating a new nursing profile, we also established certain standards. So we required a minimum of 5 years ER experience and 2-year experience in triage or advanced triage, and specific ER training was also considered, as well as training in triage and advanced triage. Other specific aspects such as conflict resolution, teamwork skills, empathy, and problem-solving skills were also very highly required. So a training plan was developed and quality indicators were defined. A specific registry was also drawn up to later export data. In November of 2019, the GITA program began, and subsequently a 3-month pilot test was launched. The end results were so satisfactory that in June of 2020, there was a definitive GITA program implementation in emergency services. In all, 39 practice guidelines were created to treat 57 chief medical complaints. With the incorporation, Okay, the results. In total, GITA treats 40% of less and non-urgent cases, level 4 and level 5 in the ER. Of this activity, 93.5% were treated and discharged autonomously, and 6.5% are transferred for medical assessment. 70% of the most frequent chief complaints were either muscle and joint pain, wounds, also acute renal colic as one of the most frequent health concerns. Initially, GITA was only treating in level 4 and level 5 cases. However, we also considered that GITA could also assume level 3 cases that involve the management of pain. The length of ER stay from the time that the patient is triaged and later discharged by GITA was 1 hour and 56 minutes, and the rate of ER readmission was very low as 1.12%. The number of complaints filed by patients was 0%. In conclusion, we have created a model for which autonomy and controlled medical practice is paramount, of highly skilled nurse practitioners that increase professional satisfaction and allow us to optimize human resources and emergency services. It is a model that allows us to value nursing skills as well as empowering these professionals, and in which we have obtained satisfactory results with the same quality and safety of care by reducing the length of wait time in the ER and readmission. However, there are necessary leverages in order to obtain these results. There are clear objectives by the ER with better patient care and sustainability of the system in the long term. Standardization in decision-making shared by the team, training, teamwork, and clear and defined roles within the ER flow. Thank you.
Thank you. So we do have a few minutes, and I want to engage the audience in the Q&A. One question that will inevitably come up, Maricel, is this whole question of scope of practice changing, task shifting, is something we've been talking about in healthcare in all countries. You've actually done it here. You've shown advanced practice nursing, how it's actually created the flow through of the emergency department. It's declogging it in a very practical way, right? Is this sustainable, and is it, again, question of acceptance? Has the hospital accepted it? Are there any standards you have to go through now in order to make this standard practice?
Que si el hospital lo ha aceptado y que si ahora hay ciertos estándares que la enfermera tiene que pasar para poder llevar a cabo este programa.
Sí, efectivamente. No solo el hospital lo ha aceptado, sino que hay un apoyo de la gerencia y de la dirección y un proyecto de implementación en toda Cataluña de este proyecto de la GIDA. Sí que es cierto que se ha tenido que crear un perfil de la enfermera muy específico porque es un puesto de enfermero de práctica avanzada y por lo tanto es necesaria no solo una experiencia y una formación en práctica avanzada, sino también otras cualidades se valoran como la empatía y la resolución de conflictos, ¿no? Es un nivel más de experiencia, por lo tanto de más nivel de complejidad porque resuelven de manera autónoma estas urgencias.
Certainly, the hospital directors and board accepted this project from the very beginning. And as we mentioned before, certain requirements were considered, such as experience, but also a certain profile that had to be created, that also consider not only emergency training, but also empathy, problem-solving skills, teamwork skills, because it's at a complex level of practice among nurses, and it's probably a program that could be implemented in the rest of the territory here.
Okay, thank you. So with that, we'll go to the next presentation. Maria Gutierrez San Miguel.
Yes.
Please, floor is yours. Would you like to present from here?
No, yeah,
Oh, yeah, of course, so you can read here.
yeah, exactly.
Yes, good.
I cannot see that. Okay, thank you very much. My name is Maria. I come from Valdebrón University Hospital, and I'm going to talk about the making outpatient consultation demands and hospital capacity meet. So the first question before I start. How many here, your institutions have problems meeting the demands of the outpatient clinics, and you have like long waiting lists waiting to be visited? Is it something that happened? Okay, yeah. Okay, yeah, I could say the same, right? It's something that happens to many hospitals here. And so these are the authors. And well, just to put you a bit in context, we did kind of a reorganization within this outpatient clinic in the ophthalmology service. So and a bit of the context is it's about like 95,000 visits a year, and the staff is like 34 staff. Ophthalmologists are 7, and 7 residents as well. These are a bit of the numbers. And so what's the context? This service, this outpatient clinic, needed to be transferred somewhere else. But not just that, but it needed to be parted. So they were visiting in one place, and they needed to be visiting in 2 places. So we needed to separate the outpatient clinic. Also, from the patient point of view, waiting times were long. They were like, we once measured the patient experience. It was like 3 to 4 hours within the hospital waiting to be visited of all the tests and then the visit with the doctor. So it was a long time. They all said, I know the time that I come in, but I don't know the time that I come out. So it was a big deal for them. And then also there was this, from the professionals' point of view, there was this controversy of the definition of the roles that they were, because they're optometrists, nurses, and we needed really to identify the roles that each of them played. So the main goal, as I said, it was, to develop a methodology that we could calculate how to develop those outpatient clinic visits, because really there was a lot of waiting lists and waiting times within the hospital. And so to do that, I work in the process unit, and we develop methodologies to calculate. I'm an engineer, and also a nurse, so we mix up both both aspects, so we can balance the charges of both demands and capacity. And one thing that we work really hard on, and that this is the basis that we work with. So we can define the tasks that we do in like 3 different levels. One is added value, which is really whatever the patient comes to the hospital for, treatments, education, diagnosis. Then this auxiliary value, which is something in between that we could talk about this forever, but I'm not gonna get deep into that. And also there's the non-added value tasks. So this is value-based healthcare. Non-added value-based tasks, I think we can all relate to this. Surgical suspensions, waiting times, calls that didn't need to happen, And if I asked you, what do you think? What's the percentage of each of these levels take, average of any hospital? Evidence is not that clear about the first 2, but the evidence says that the last, it's about the 50%. And this is harsh. This is really hard to swallow. It's a hard pill to swallow, really, because it's like the same as saying that from July to December, we don't do anything, or we don't add value. Well, we do know that we really are sweating all around the corridors of the hospital. We do a lot of things. What means this is like whatever we do, it doesn't get in the shape of value from the patient point of view. And this is really important because when reorganizing, pathways, we need to take all this non-added value tasks off our pathway so the value can increase. So we have waiting times. Why is this? So if there's no perception of professional satisfaction among the staff, why is this? Because everything is going to come out as an outcome. Safety errors also are there. So what we did is we mapped the process. We detected all the non-value tasks, which are the pink ones that you see. Also, we had an exercise of direct observation among professionals. So optometrists observed doctors observed the administration person observed doctors. We crossed them all up so that they could see all the non-value that each of them had. Because the non-value is not something that I want to do. It's just about pathways that need redesigning. So, and it's not my fault if I'm, covered in non-value. It's just a pathway that needs to be redesigned. So everybody knew what the other was, undercover. So these are the interruptions that they felt. Also some results, there were waiting lists, waiting times, unscheduled visits, a lot of spontaneous visits, and multiple way flows. The coordinating the test was the most difficult part because this is the analysis. It took we know that for each visit, patients go through 4 to 5 tests. So we need to coordinate 5 visits actually for one patient. And this is what ophthalmology is about. So what we came to is that we needed to reorganize per clinical pathway. And that's the key point. It's not the same, the time of the first visit for a cataract to the first visit to a neuro-ophthalmology visit. It's not the same. So we need to assign the times per clinical pathway and per test. So that's what we did. Clinical pathway number 1, which may be cataract, we characterized it by the tests that needed to be done, by the times that took each of the tests and the visit. Pathway number 2, it's, macular degeneration, also took the test and the times of each of those. So that now we know how to reorganize. Once we do that, and this is the important point, because now our former organization was the first visits take 10 minutes, the follow-up visits take 5 minutes, and all are the same. That's not how it works, because patients and conditions are not the same. So we need to adjust per clinical pathway. And so done the calculus, this is what came through. So these are, for example, in the column, there are the different rooms, and in the x-axis, there's the capacity. So we knew, this is, for example, Monday. We now see that on Monday, there's one room that's going to be twice-fold overloaded. And necessarily, the red one is going to make dysfunctions in the red outpatient rooms, which are 1, 2, and 3. Because tests are not going to be done, so they cannot visit. So we need to reorganize so that we can make the full capacity but not overload it. So the waiting times are going to adjust. And this is just done by clinical pathway. We cannot do it generally. So this is how we were organized, and I have to say, calculus, methodology, and everything, yeah, that takes something. But the hard point here is the cultural change that lies under this. Because we're not used to this. We're not used to this. We're not told, I mean, we're used to, be organized somehow. On Mondays I do that, on Tuesdays I do that, but we're not used to reorganized around the patient demand. And clinical pathways are actually the patient demands. So we implemented this. First of all, we separated, the patient flows that needed testing, which were the ones that were a bit dysfunctional, from the ones that didn't need testing, and that improved waiting times. Also, what we did was a definition of the implementation per test, and we configured it in the ER, in the clinical record software. So we could reduce from 15 to 30 minutes per ophthalmology the visits. So this is non-value taking off the pathways. And for sure we did this cultural change, and we're still on it. I mean, it's not, I'm not gonna say it just did work. It takes time, and it takes readjustment. So in conclusion, this is not really fully implemented, because due to the COVID-19 situation, the job constructions that needed to be done are not done yet, so we cannot move the outpatient clinic yet. But I have to say, while implementing it, this is the conclusions I get. I mean, cultural change, yeah, you have, the left side of the brain with, the method and the calculus, the technical stuff, but you have the right side of the brain, which is the expectations, the fears, the resistances that comes with change. And really, I mean, the job is about like 70% right-sided brain, 30%, left-sided brain, because that's the change. Like the U here that you see on the slide, this is how change works. We start super happy, then we see, ooh, this is getting, really tough. We get to the bottom of the U, I'm quitting it, it's just about resistances. My colleagues hate me because I'm the face of change. I'm quitting this. But then when you overcome this, you have to overcome this, then it gets better. The U keeps coming up, so you end up better than you did when you started. But it takes time and it takes effort. And that's the thing. My conclusion is about cultural change and also, of course, technique, but mostly cultural change to do this. Thank you very much.
Thank you. So, Maria, before you go, just one quick question. So this is an example of all the shifting changes. We talked about taking the hospital outside the hospital, essentially. What are the innovations? These are innovations happening within the facility to meet supply and demand. So one question that comes up, Maria, is a lot of things you say are quite common. The one thing, though, you mentioned is cultural change is difficult. Have you found that during COVID, making all these changes was a bit easier because there are so many methodologies and frameworks we use in hospitals? It's amazing. We're all technicians and we're clinicians as well. Mm-hmm. Did you find it easier to make the change during COVID?
Yes, because there's a sense, as Scotter's model says, there was the sense of urgency that you need to have when are implementing any change. Mm. So with COVID, the sense of emergency there was everywhere.
Okay.
So that for sure it helped.
Okay, thank you. So with that, we'll go to the next one. A presentation by Joana Seringa, who's the operation room manager at Centro Hospital Universitaire de Lisboa in Lisbon, Portugal. Over to you.
Thank you. Hello, everyone. Thank you, Dr. Salim. So my name is Joana Seringa. I am from Portugal, and I'm going to present to you, maybe I can take this, our project that it's called Macro Process of Surgical Patient Management. And to contextualize, we are a tertiary care center composed by 6 hospitals, and we have at least 2 operating rooms in each hospital. We know that operating rooms are a centerpiece of healthcare centers, consuming a lot of our budget, and a place that interacts with all of the other clinical and support services, presenting a high complexity. At the beginning of this project, we identified that for each hospital, we have different cultures, different ways to to work. And we didn't have standardized or guiding or monitoring systems. So everyone was trying to do their best, but in a way that was confusing. And so we decided to map this process, and we identified a lot of spots to improve. It was, as I was saying, it was confusing, the process of the surgical patients. We were having limitations, so low production, low productivity, and a lot to improve regarding the quality of the service provided. Namely because we had a huge number of cancellations at the same day or the previous day of the surgery. So we, based on the literature, decided to map and do a new process. So we defined stages, sub-stages, activities, response times, and the responsibilities that were really diffused in the process before. So we did it from the referral to the follow-up consultation, and we have here the main stages. So the referral, the waiting list, we have the scheduling, the pre-intervention, the intervention, and the post-operative. And there, the follow-up consultation. And in here, we defined the activities and the response times and the responsibilities. And we, in a co-creation process, we called frontline professionals to look at this new process and ask them to help us to improve that process, that new process that we had designed. We made small groups of 12 professionals, at all group professionals, and we had some pretty amazing inputs. So we defined a new version, and then we present again for that professionals and for intermediate managers like chief nurses, the medical responsibles for the specialties, hospital managers. And once again, we had great contributions. So we made a new and final version, and we defined key performance indicators for each stage. And then we started to implement it. We are glad to have good results to present. So with this, just mapping the process and bringing people with us to look for that process, we had a decrease on the average time for surgery, almost 18%. And also, we started to schedule the surgeries in more time between the scheduling and the surgery. Also, we decreased the same days and the previous day cancellation rate. But this is, this was the basis of our project and what we want to achieve. Right now, we are looking for the value equation, so outcomes in the perspective of the patient and the cost per patient. We are defining the implementation phase of the prompts, and also we already have a pilot in the operating room and in a surgical pathway of the cost of the surgery per patient. So maybe next year I have some new results regarding this, the continuous of this project that is really a continuously improvement project. So yeah, that's it. Thank you.
Thank you. So Joanna, before you go, just a quick question again. So you're doing a lot of innovations internally in terms of changing the practices. You're looking at patient-centered care. You're looking at really focusing on the operating theater and efficiencies. Did you notice a sense of urgency during COVID? Because initially during COVID, I mean, hospitals really emptied out. And then, of course, patients did come back. So whilst you were doing this thing, was there a sense of urgency to actually complete this? Did you have the authority around this project?
Yes, so we started the project before the
COVID, okay.
before the COVID, and we start to look at great changes because everyone start to know where I make the change, what are the response times, when can I do my part, and with the COVID we continued the project. And now that we are feeling more patients are coming to us, it makes more sense than ever, because now we feel that we can continue to have these projects and to improve it. Yeah.
Okay,
So,
thank you.
Thank you.
So with that, we'll go to presentation 6. By the way, this musical chairs does work, so if you guys want to come here, it's probably better if you can see this, right? Yeah, you can come over. So the last presentation is the Curel system, a new patient classification system for hospitalization developed in Catalonia. And we actually have 3 presenters, so over to you.
Okay, thanks to you all to be here this afternoon. Well, the presentation? Okay, thank you all for being here this afternoon. My name is Marc, and with my colleague Julia Folguera and David Monterde, we are going to present what we call the Curel system. That is a new tool for hospital patient classification developed here in Catalonia. The presentation will consist of 3 parts. In the first one, we will define briefly what is the Curel system, and we expose its benefits compared to similar tools. Secondly, we will focus on the practical application. We will review 3 researches that make use of Curel system. And finally, we resume the main ideas here exposed and the future agenda that we have in mind. And also, we encourage you to download and try this software that is freely available. I'm going to take care of the first half of the presentation, Julia the second half, and if there are any questions, David Monterde will be very pleased to answer you. First things first, let's give some context to the Curel system. As you may know it, case mix quantification is not a new topic. Since the 80s, we have several tools. One of the most known tools is diagnosis-related groups, DRGs, that are widely used and they focus on the billable and economic aspect of the discharge. It considers diagnosis, procedures, comorbidities, etc. Also, we have Charlson Index and Alex-Hauser Index that groups some diagnoses and gives a score of the risk of that diagnosis. And Curel system tries to take the best of all these worlds. As Charlson and Alex-Hauser can output an index that gives a number to the risk of the patient, and also can handle comorbidities and financial aspects as DRGs. As it has been said, Curel system outputs also index and categorical values, and also is modular and can be aimed to the focus of the main interest. You can aim to risk, resource consumption, severity, or a global output. This is an example of the input data expected and the output carried out by the Curel system. The input data is the classical administrative data. We need the patient data, the patient characteristics, the administrative data of the discharge, also the clinical data as diagnosis, comorbidities, or procedures. The output, as it has been said, is a numerical value that weights the risk of every diagnosis recorded in the discharge. And Curel groups are, as DRGs, a categorical value plus an ordinal value that from lowest to highest tells how the severity or the risk is at discharge. And why Curel system? At this table, we compare Curel system to the other tools here exposed, and we can see that Curel system is the most complete analytical tool. It's similar to DRGs, but with one significant difference. It outputs categorical and numerical data, and also it's open source and free. You can try in your home. Let's begin with three research and application. This first research aims to compare Charlson, Elixhauser, and DRGs, and we want to compare these tools, the performance they perform as to predict in hospital events. We want to predict three kinds of events: death, long stay, or the need of intensive care. And for all of these, we build regression models based on logistic models. And in every model, we play with one or other variable. We evaluated all these models through the ROC curves. As you can see, the chiral index model, that is the dotted blue that is in the high place, is outperformed all the other models. And more clearly, here we can see the area under the curve of the models. As you can see, the last model based on chiral indices outperformed by far the base model and the other models behind him. Now, second research that we want to highlight is the predicting of critical illness in COVID-19 patients. As the research before, we define an event that is critical illness, define it as the need of invasive ventilation, the need of ECU, or death. More similar to the other research, we build 5 models, we use logistic regression, but with one difference. In this case, we only use chiral index based on comorbidities. We want to predict before it happens that 3 events, so we only based on the diagnosis present on admission on the patient. There's an interesting result. The first one, we try to quantify the effect of every model. As you can see, the first is the base model, age and sex. Age accounts for the measure of the significance. Then we add Charlson index. It is important, but age still have the measure weight. Then we try Elixhauser, no big difference, but finally we use chiral index based on comorbidities, and happens something super interesting. The age becomes non-significant, and all the weight is carried out by chiral index. Finally, there we have the ROC curve to perform the performance. Again, chiral index outperform the rest of the model, and as we want to predict, we use precision recal plot, and also outperform the rest. And I finish. Now Julia take the floor, and she will explain the economic part of chiral index. Thank you.
So thank you, Mark. So now we are going to dive into the economic part. Sorry. Okay. Having a fair cost accounting system is crucial, since it enables hospitals to better understand and compare their allocation of resources, as well as to split the budget. Nowadays, the most used cost accounting system is the DRC, as my colleague has already explained. Our chiral system was not initially designed for this purpose, but we'll show that with a small modification, it could also be really useful for this task. So what we want to do in this research is to compare the classification power of DRGs and chiral system in trying to disaggregate high-cost hospitalizations. We will be working at program hospitalizations, and for all of them we have the real cost, as well as the DRG and chiral indices. We have constructed with the logistic regression method 4 different models, 2 of which use the DRG system and 2 using the chiral system. We have defined what is a high-cost hospitalization in different ways. First, we defined it as the 5% highest cost hospitalization, then the 10, and finally the 20. Here we have plotted the ROC curves, and we can already see that there is a global trend among all the models to perform worse when having to deal with a more equilibrated data, so in the plots of the right. Also, we can already perceive that chiral system models outperform DRGs, but this can be more easily seen in the next slide, where we have the area under the ROC curve. Here I would like to point out 2 things. The first one is that what I have already said, that chiral models outperform DRG models. Also, I would like to notice that between models of the same system, the one that perform better is the one that only have the subindices related to resources. So DRG severity will perform always better than DRG global weights, and the same will happen with chiral resources. And with this, we came to the end of the presentation, in which we have introduced the chiral system, a new tool created taking the best of indices and DRGs. We have proven that chiral system outperformed indices and DRG in risk adjustment, classification, and prediction. With the results in hand, what we aim for now is to externally validate the results to see if in other populations it performs as good as in the Catalan one. And now that you have seen the results of the chiral system, we would like to encourage everybody who wants to know more to download and try the free tool, which is available as an executable file or an R function. You will find all the needed information in the webpage, and if you want the most up-to-date version, you could also send a mail to us that is at the end of the presentation. And this is the bibliography where we have of the presentation, where we have our own published papers as well as some other classics we have used. So thank you very much for your attention.
Thank you, Mark and Julia. Thank you. And again, David, as the Q&A starts, if there are questions, we'll address it to you. So did you have something to add? You're welcome if you wanted to add something. Were you presenting or Q&A? Okay, so why don't you guys sit together? So with that, we'll just break for questions now. You guys can be seated. Yeah, can have a seat. So with that, what we're going to do is we'll just break for some Q&A. We have some questions that have come in, but I want to give you the opportunity to really ask some of the key questions you have on your mind. So as you ask the question, if I can just ask you to introduce yourself briefly, who you are, and then you can just pose the question. So anyone has any particular questions to address? Please go ahead. We'll have to use the mic here.
Thank you. Jordi Piera from the Catalan Health Service, here the public insurance in Catalonia. My question is for Mireia. I thought, well, thank you for your presentation. I think it's very relevant to, well, all the tasks that you have done when reorganizing a big tertiary hospital, a university one with plenty of, as I say, white coats moving all across the facilities with, I would say, no real direction, or you have the feeling that, well, there's a bit of disorder in there. So anything that helps to better organize this, it's a good thing. The danger with all this reorganization process, according to my view, is that yeah, they may lead, I mean, for hospital managers, it may lead to more, well, increased productivity with free time of professionals, and we may have the idea, let's fit more patients in the same amount of time because we have free time. I am obsessed with, yeah, just trying to give better care to the citizens. So, I mean, maybe freeing time to, yeah, take more compassionate or more proper care with patients, touching them and having the time. Was that the situation, or you have been forced to add more patients into the time that you have been able to free?
Thank you. Any of the panelists, you can address that.
The thing is, when we reorganized it, it was intended just to do the same amount of patients, but to give them more quality. Actually, we're now on our way to implement the programs in those clinical pathways, because we want to measure that. We want to really do that. We understand that from those waiting times that we're now avoiding, it is time that professionals were, looking at computers instead of looking at patients, and now they are looking at patients. But there's still a lot of non-added value tasks that needs to be removed from those pathways. But it's intended, to give, because, I mean, COVID happened in the meantime, so I cannot really speak about numbers because, all the waiting lists were, piling up while we had attended COVID, so we don't really have the before and after the intervention values now. But I don't think it's intended to be with more patients, because waiting lists were already really adjusted, but they were on time. And now it's the same, they were on time. It's just that this time that we've freed from professionals, it's about giving more care to patients. Because one thing that we understand when applying these methodologies is like, there's no takt time, in healthcare. It's not like a factory that, like this transportation, carrying, it takes like 1.2 seconds. It's not like that. Sometimes patients, just by entering the door and sitting there just in front of you, take a lot of time already, because these are patients, it's people. So we want to, by removing those non-value tasks, it's allowing those patients to have this time with the clinician.
Joanna, did you want to add to it as well? I mean, this whole question of improvement, efficiency, effectiveness, I mean, it's a valid point. At the end of the day, healthcare is a human sport. I mean, it's a human contact, right? You're dealing with patients and people. So do you find any, with respect to that question,
Yes.
are there certain things that you need to express once you were doing your project?
At our project, the main thing that we wanted to address was exactly the quality of the service provided, and especially trying to reduce the cancellations that we were having. And try to make it clear for everyone what was the process, including for the patient, how everything is going. Since I entered at the waiting list, what happens to me? What are the stages I have to do? So all of the process was designed thinking about this transparency of the process and the quality for the patient. Not, of course, we might have possibility to do more surgeries, but that was not the main aim of our project. It was to improve the quality.
Yeah, and I think that's an important point, because at the end of the day, when managers are tasked with certain performance indicators and things that they want to accomplish, it was very clear that quality and throughput was important, but not the issue from the standpoint of pushing more people through. So I think that's a very valid question there. Other questions, observations? And by the way, you don't have to just ask questions. If you have any particular observations with respect to any of the topics we've talked about, you're very welcome to address that. Yeah, please.
I have a question. I'm Marc Potter from Paris. I have a question for the colleagues operating in hospital at home. We have seen two different models. In one, as far as I understand it, the physician in charge was the medic of the hospital at home. And in the other one, the doctor in charge was the one of the emergency room. And we could have thought of a third model, which is the GP in charge of the patient. And I would like to know if, for you, what is the best model? Or said differently, if you had to do it again, would you change something?
Good question.
Thank you. Thank you very much for the question. For us, that's our way to operate from ever. It's to have our own staff at hospital at home. And if you ask me which one is the best model, this is the one I know. And for me, it's the best one. But I understand that it's difficult to have the enough staff to cover for this amount of patients, and in some hospitals, in some second-level hospitals or smaller hospital, or where hospital at home units are starting or are still small, it can be a shared model where the emergency room physician or the internal medicine physician in the ward can do this work. If you ask me, I prefer a model where you have physicians and nurses dedicated to this work, because it's not the same to operate in an emergency room than in the home of a patient, and you need to commit with the unit, with the service, and with the model. But that's my humble opinion, and but I'm open to other models for sure.
And that's a very important question, because many health systems are grappling with that issue right now. And the interesting other finding, to add to what David was saying, every health system is actually devising something. They're interrogating their peers. They're talking to other groups, but they're actually developing their own model. And there's a lot of movement right now in terms of definition of hospital at home. So I had a colleague yesterday I was speaking with, and she's actually in charge of the outreach program in Pakistan, of all the places. And they've actually devised a program. They have a hospice at home program. And they provide full support. They provide everything, including staffing. So your point is an important one. Every health system is figuring out what actually makes sense. Now, at some level, I think from what David said, some systems are starting from the emergency department and saying, how do we create, how do we decant emerge and see that? So I think that's a very valid question. I think most health systems are trying to figure it out. And there are many different models, I think, that will come about. So that's an important question. Other issues? Yeah, please.
That's a very short one, also for the people that have been explaining experiences with that home hospitalizations. Do you do any kind of pre-qualification of the home of the person, or you have some kind of requirements to assess that the facility is good enough as to have this person hospitalized at home?
Yeah, David, go ahead. And again, just Len, if you're...
Sorry, I haven't heard the question.
So do you mind just quickly... No, it's okay. I don't want to mince your words, so ask the question again.
Yeah.
Yeah,
sorry.
Speak to the...
It's Caridad Pontes from Cat Salud here in Barcelona. I was asking regarding the experiences for hospital at home, if you are doing some kind of pre-qualification of the home of the patient to be sure that that's suitable for providing this care.
Yes. In a usual model in France, we have this pre-qualification, and that's why, in average, we have 2 days from the decision to hospitalize at home and the real discharge. But in what we presented, we hadn't this pre-qualification, so the respect of the criteria was essential. Because, for instance, we needed to have always a presence of a caregiver at home, or we needed to have a safe home. And normally we have this pre-qualification, but in this case we hadn't. And that's why that was a shift of paradigm for us, because it's not our usual habit, and that we want to work on it, because that's what hospitals ask us currently.
David, you want to add?
We don't do any assessment prior to admit the patient, because we don't have the time. We understand our care as a very acute care. Our normal average stay is about 5 to 10 days. So we prefer to, we like surprises. Okay, so we prefer to take the patient home as soon as possible. What we do is a evaluation of the caregiver that are going to be present in the admission of that patient, of their family, or their husband, of the wife, and we do some qualification, education for this caregiver, but it's like a very fast and very quickly, in order to mobilize that patient to their home as soon as possible. And I would like to ask you, if now that you experienced the other model, this surprise model, did you find a lot of homes that weren't in good conditions, or you need to transfer back patients because we don't find that so often?
No, not a lot, but when it happens, it's always difficult. And in the case we said we had 35 people who were readmitted, and a few were because the criteria was not respected. For instance, there was no caregiver at home, or for instance, it was the hygiene conditions were too bad to be able to have a hospital at home. It was very rare, but it happens. So, but we know we have to tend this kind of model because to try to discharge the most quickly as possible.
So, one of the things that's coming about based on other questions that came the last 2 days, some of the issues in terms of health at home, hospital at home, the whole question of reimbursement is now going to come about. So there are key questions here, right? Exactly what does the model look like? And there are many models that come about. Then the question of reimbursement is going to be there. The whole question of effectiveness of care. So I think all the models that are being piloted right now, as long as there's some element of research embedded in it, because we have to show the evidence. This is one of those that some research, some evidence will have to be shown. And then the whole question of, is this something, how does it get reimbursed? It's a very key question. I think as we also, with the whole question of digital and home health and telehealth, many issues came with it. So as much as it's a method that works, the whole question of how do you reimburse for it? Now, I think during COVID, what happened was many health systems decided to reimburse it. They piloted it quickly, but now it's become part of something that will stay most likely. So I think around this whole question of home health, hospital at home, the question of reimbursement is now going to come about. Is it effective? How can it be more effective? How does the GP get involved? And how do we reimburse for it? So I think these are all questions that will come about. With that, I wanted to sort of ask question, the whole question of, you've done the DRG work, you've shown value. How do you get this now into implementation? I mean, does this become a research project that you go with one health system, or does this get into the mainstream of delivery and payment? Where does that research go?
Well, in fact, it's easy to implement because we use administrative data, and this administrative data is available in all the systems. Okay. We need the most basic information that we need are diagnosis codes and procedures codes. So this information is available in most hospitals.
Okay.
Even if we have enough information, we can recalculate all the model with your own data.
Okay, fair enough. Thank you. So again, we're still in a Q&A mode. I have some questions, but I'll defer till we get some of your questions responded to. What other questions do you have on your mind? And again, have you any thoughts of your own, other things you have seen which have been quite effective with respect to the whole question of moving services out of the hospital? And there was a presentation this morning we heard, and one of the presenters was basically saying that we will have to figure out what the role of the hospital is. Now, interestingly, I'm a hospital operator, so I'm like all of you, caught in the middle of something that's happening as we go. So, one of my thoughts was that the role of the hospital, we're actually figuring it out as we go. Because I don't think we have the luxury to stand back, because these are operating 24/7 institutions. So I was curious in terms of, your thinking, because, my thought was that, like I said, we are in the middle of a major transition. We have to operate the facility. It goes on 24/7. We're figuring it out as we go. So in a way, it's a bit like, taking a big Airbus, which is in flight. We don't have the time to park it and figure out what the role is going to be. We're figuring it out as we go. So I'd be curious to get sort of your perspective. We've come through COVID. We've seen what now the home healthcare is what the hospital movement out is. We've seen some of the initiatives taking place within the hospital. And right now, as the presenter said, there's a lot of impetus to get things moving. So new standards are coming, new quality standards are coming. Where we used to do things which took maybe 1 or 2 months, now the staff are getting authority to move quickly. So do you have any thoughts in terms of how you see things progressing now in your own institutions? I mean, based on what you've heard today, and also based on your experience. It'll be interesting for you to share some of your thoughts in terms of what we've heard the last 2 days. Please, go ahead.
You touched that point before, and it linked to the model of the hospital at home, but I mean, the people in the table, they have not spoken about this, which is the introduction of digital health and telemedicine, all these sort of services, especially within the pandemic. I mean, it was technologies that were already there, but, well, they meant a great opportunity now to ensure continuity of care, to avoid possible contagion of professionals and citizens, and to protect healthcare centers of all of this. I am curious because we know, well, here in Catalonia, we have had a huge deployment of such technologies, starting with telephone, but also the video consultation and also the synchronous mode, with a great explosion of the patient portal that before the pandemic was not much used, but afterwards now we have like, I would say, 75% of our population already registered and using it. I would like to see how this stays because, as you were mentioning, there's no reimbursement model for this. The health service, we are still reimbursing activities, face-to-face ones, and I would like to hear from, I don't know, the colleagues in the table or anyone else in the room, which has been their experience with the teleconsultations and all these remote.
Sure. I think that's an important question. So again, a question to the panel. I mean, anyone who feels inclined to respond to that. We've been adjusting to this whole question of remote health, telehealth, in whichever way it is seen to be effective. Do you have any opinion on that in terms of, is this something now that's here to stay? Is it an effective mode? Where are some of the gaps? What are some of the issues we need to sort out? Because I think we can all agree this is now here to stay. Right? We've been experimenting for a while, but it is a modality that's here to stay. So what is your opinion in terms of its effectiveness, the issues we have to sort out? Anyone from the panel? Yeah, go ahead.
Yes, in a hospital at home, we have a habit to work with digital tools. It can be teleconsultation, it can be telemonitoring, but what we've seen during the COVID period is that was, for instance, when I spoke of problem of interoperability of information systems, it was just crazy that our nurses had to double entry the data. So I think there is one problem of interoperability, and another, as you said, is in the question of an issue of reimbursing. We want to develop telemonitoring of high-risk pregnancies, and in the French law currently, we have to be at the patient home twice a week. So we make telemonitoring, but twice a week the midwife has to go to patient's home. So there is also questions of financing laws. I don't know how to say, but to you, I think you get what I want to say.
So I think the important point here, which we covered it, but I think it's important to reinforce it, that we have telehealth, teleconsult. We're also talking about telemonitoring, the whole question of monitoring remotely. I think the very natural add-on, which we're all getting accustomed to, I know it seemed novel before, was smart watches and smart tools. It seemed like a novelty, but now it seems that within a couple of years, it'll become pretty standard practice, because this is part of a remote monitoring tool anyway. It just sits on your arm, on your wrist. It becomes part of your remote monitoring. It'll be able to monitor everything, rhythms, heartbeat, the whole thing. So I think this question of remote is probably here to stay. I suppose the question is for you, on the assumption that reimbursement will follow. It's a difficult process. Usually, when it's new, it's difficult. Do you think this is now something as a modality that's going to be here to stay in the jurisdictions you're working in terms of everything we've seen, right? Remote consult, remote health, remote monitoring. Do you feel that this is now going to be here to stay? You think so?
You're asking me?
Yeah.
Yes.
Please. You have direct experience.
I think it will continue. That's a good point of the mic.
Yeah, on the mic, please. Yeah.
Yeah, I just said that I think it will be continuous. That's a good point of crisis. But as you said, reimbursing issues are always a bit later than the reality. But I think it will be continued.
Okay, good. Yeah, please.
About telemedicine and remote monitoring, for example, I think one important thing is that the most difficult part for me is not the tool. The tools exist, they work. The problem is you have to put the right organization with this. So if you collect data on the patient, who is going to look at the data 24 hours a day? How do you treat this information? How do you organize the comeback of the patient at home, etc.? So for me, the difficult part is not the electronic tool. The difficult part is the organizations that have to change. And you have said how difficult it is to change the organizations.
So important point. Do you have any observations on that? I mean, we're talking here about making change in the hospital. You guys are leading the change. I mean, even though these are projects to improve efficiency, improve throughput, but you're engaging in change, right? So what are some of the issues that you face day to day? And how do you think you'll be able to change? I mean, how do you manage that process of change? Any thoughts on that? Anyone? Go ahead.
We do have a methodology for change management. It is so true that tools are tools, and they are there, and there are many possibilities of tools, actually. The thing is the organization behind that tool. And also, we have to ask the patient if they want that tool, because what happens to us is, for example, we're measuring PROMs in some pathways, and we've seen that patients answer them if they have feedback afterwards. If it's implemented in the clinical daily practice, if they go to that patient clinic and the clinician tells them, yeah, I see your anxiety and I see they will, implement the form because they have looked at it. But if there's no, feedback on that, they will stop sending the data. So I think it's about the cultural change that lies behind all of this. Because, and also, it was not that long ago that I read an article about value-based healthcare, and which formula we all know, like outcomes divided by cost and blah, blah, blah. But it seems like it's getting the turn, and it's outcome plus trust. So I would say telemedicine is here to stay, but let's not forget about the plus trust thing, because some patients still want one-by-one face-to-face visits because they feel like they need, that confidence and that personal feeling relationship. So I think it's come here to stay, but it's not leaving behind the personal contact.
Yeah. Any other thoughts on that? I mean, leading cultural change. Yeah, go ahead, Ghislaine.
I would like to say that regarding the telemedicine and even with the fulfillment of the questionnaires, what I feel from the patients is that, we have a burden associated. So the person has a disease and has to manage the disease, and also it also is always being telemetrized and fulfilling questionnaires like what do you want more from me? Yeah, and I think that is something we all have to really think about it. That is, how can we have this information and work based on this information that is crucial to make decisions and to improve the quality of our service. But how we can do it without being an additional burden for the patient. And I think that it's still not answer it, and we have to think about it, like ways to do it without, yeah.
No, fair enough, Joanna. So I think to the point of culture change, and one issue that comes up a lot, which you all are impacted about, is leadership. So at the end of the day, at least from a perspective, it's not the perspective, it's just one perspective, that at the end of the day, change, leadership makes a big difference. It has to come from the top. So the leadership that you're dealing with in your own health system is going to be crucial, because at the end of the day, tools and methods are there, right? Technologies are there. The question is, how do you organize? How do you frame it? How do you motivate the staff? And that, for me, is always a leadership issue. Do you have leaders who understand the importance of motivation? Because sometimes I think we get fixated too much on the tools. We get fixated on the metrics of things. At the end of the day, healthcare is about helping people. It's about this human touch. So I think that's a very valid point, that at the end of the day, we need to keep that piece in mind. And that, for me, then brings up sort of one question I want to ask all of you. And it's a difficult question because, in a public forum, it's a bit difficult to fess up. But do you feel you have the kind of support from your leadership? Because at the end of the day, if you were to say change is going to happen if we have that level of leadership, then my question for you is, do you feel that you have that level of support in terms of leadership from your own institutions? I mean, how do you guys feel about that? Well, let me ask it a different way so I don't put you in a difficult situation, right? Do you think leadership is an important attribute in everything we're talking about right now, right? Moving, change, culture change. How important is leadership, you think? Go ahead.
Sí, efectivamente, yo creo que lo más importante es el apoyo de la dirección y de tu propio equipo, ¿no? Porque ideas tenemos todos y buenas ideas tenemos todos, ¿no? Pero lo más importante en la implementación no es solo el trabajo en equipo, sino también el apoyo de la dirección y del equipo, ¿no? Es fundamental.
It's very important to have support from the higher ups because it's in the end, it's all about teamwork and team building skills. So yes, it's important to have support, and at the end of the day, it's about teamwork.
Okay, well, thank you. Well, I apologize. I've gone over limit. I wanted to stay within the time frame. We've gone 3 minutes over. I'm going to ask just one last thing. If there's anything final anyone wants to add before we close. You're not compelled to, but if anything that you feel is on your mind, anyone from the panel? No? Well, with that, I just want to thank the panel. I want to thank all of you for being here. I want to thank all our remote folks beaming in from around the world on this session. I hope it's been a useful session for you. This whole area of home, health, hospital outside the walls, all the changes happening within the hospital, you've got a flavor of some of the key initiatives taking place. And I think you've got some of the key takeaways. So I'm not going to be wrapping up anything because you've heard it from the panelists. So thank you all for being here. And hopefully you have a wonderful news session going on. There is an award ceremony taking place today, so please attend that as well. But with that, thank you very much for coming. Thank you. Thank you, everyone.